Thank you very much, Mr. Chairman, ladies and gentlemen. I have a challenge today with all of you, which is just to convince you that cancer is an important risk factor for acute kidney injury after contrast medium. And the reason for that is that many of the guidelines have been changed recently in terms of the risk factors. You see, this is the previous guidelines showing the risk factor for contrast-induced acute kidney injury. But in the new version, as you can see here, many of these factors have been eliminated, such as age, diabetes, advanced heart failure, and many of them. And we nephrologists and some radiologists, we do not necessarily agree with that decision. And the reason is that many of the exclusion criteria are based on observational retrospective study with important selection bias and very low degree of evidence. So, but I need to concentrate that in cancer patients. Why cancer should be considered as a risk factor for post-contrast acute kidney injury? First of all, the cancer patient, they have a high incidence of acute kidney injury. In many different studies, 17.5%, or comparing with non-cancer patient, 5% versus 12%. And also in this critically ill patient, the acute kidney injury incidence is really high. You see, this is these new studies that introduce a number of patients, such as 29 million patients, big data studies, right? And these are including about 1 million patients with cancer. And the total absolute risk of composite of acute renal adverse event, as you can see at the bottom, the patient who received the contrast medium increased ×3 the patient who do not receive contrast medium. But if they receive contrast medium plus cancer, then increase even more. And at the same time they receive contrast medium, they have cancer and some stage of different chronic kidney disease. The percentage, the total absolute risk is really high. So that's one reason. More incidence of acute kidney injury, but also chronic kidney disease, as you see in the previous slide, is very, very important risk factor. And many of these cancer patients, they have chronic kidney disease stage 3, 4, 5, which is a GFR lower than 60 milliliters per minute. So I mean about 18%, 20% they have chronic kidney disease. In some studies, even more than that. In our observation that we did in a study in 40,000 patients in Spain in different centers, so we look at, in hospitals, we look at the percentage of cancer patients with low GFR, lower than 60 milliliters per minute, stage 3, 4, 5 of chronic kidney disease, and we found 18%. So there is another reason, not acute incidence, also prevalence of chronic kidney disease, but the cancer patients, they are living in an atmosphere which is very nephrotoxic. You know, 50% of the anti-cancer drugs are excreted in urine, and 80% they are receiving several different nephrotoxics at the same time that they receive the contrast medium. So they have diuretics, anti-inflammatory drugs, and many other these chemotherapy, checkpoint inhibitors of cisplatin and so on, that they interfere with the renal function. And you know perfectly better than me that the proximity between chemotherapy and contrast medium increase the risk of acute kidney injury in high-risk patients. And I consider high-risk patient the cancer patient, regardless they receive the contrast medium before or after chemotherapy. And also, what is important as well in cancer patients is that they receive the very frequent contrast TC. And you see, this is an Anderson Cancer Center with more than 3,000 patients showing that intravenous contrast media use is strongly associated with higher odds for acute kidney injury. Or this patient, because the guidelines in radiology, they have prescribed that, they receive, for instance, for thoracoabdominal CT with contrast every 3 in colon and so on, of 6 months in the first 2 or 3 years, and even more. And if they are introduced in a clinical trial, even more. So the patient with cancer, they have high incidence of acute kidney injury, high prevalence on chronic kidney disease, nephrotoxic atmosphere, and at the same time very frequent studies. And you see in this study, the repetition of radiological studies increase the risk of acute kidney injury. You see here more than 2 in the SR radio for end-stage renal disease. And now it's important to know exactly what is the renal reserve function is, because many of these number of contrast media studies, they could interfere the renal, what we call the renal functional reserve, and we do not realize and we do not detect that there is any kind of damage there. I propose you a question. You consider that can be a kidney damage without elevated creatinine? Yes, of course. And this is the renal functional reserve. In normal people, if they intake, for example, 1 kilogram of meat, protein, or they receive a perfusion with amino acid, they are able to increase the normal GFR from 120 to 160. Look here at the bottom, the vegetarian, even more. This is what is called the renal reserve. And when kidney injury occurs, the reduction of glomerular filtration rate is compensated by the use of renal function reserve, so that we lose functional reserve and we lose nephrons, but still the GFR is in the normal range. So this is very important, because receiving contrast media in a nephrotoxic situation continuously could interfere with the renal damage, and we could not undetect this reduction in GFR, in renal function rate, but at the end there is a reduction in GFR. And I want to talk about osmolarity as well. Why? Because, you know, the kidney, they are living in a hypoxia medium, and is very sensible to hypoxia. You see this little bird, ivory gull. This bird is living on ice. You know what is the blood temperature of this bird? 36 degrees. It's possible. All the time with the feet on the ice. And the reason is a very funny structure of the circulatory adaptation. So they have what is called the counter-current heat exchange, so that the vein and the artery are very close each other. And when the temperature is decreasing in the artery, receiving the heat is received by the vein. So they don't need to eat very much to keep that temperature. So it's the same which happening in the kidney. The kidney, as you can see here, they have the same hairpin loop pattern. And in the oxygen, now it's not the temperature I'm talking about oxygen, diffused directly from the venous branch, you can see, from the arterial to the venous branch. So that at the end, at the top of this medulla, there is a severe hypoxia, very severe. But this is the price that we have to pay for the concentration of the urine. Otherwise, we should take about 50,000 calories per day. But thanks to this mechanism, we can concentrate urine without damage, without such a calorie consumption. So So the kidney is very sensitive to damage, and particular to hypoxia, because the kidney at the very inner point are living in hypoxia. If we perform some studies introducing osmotic agent, what could happen? Well, what just happened is that this osmotic agent introduced in the blood of the patient, they have different effects: hemodynamic, oxidation, and tubular damage. First of all, there is a slight vasodilatation and immediately vasoconstriction with a reduction of the oxygen pressure and in the medulla. And this hypoxic injury, because there is a decrease in nitric oxide and increase in endothelin when the osmolar contrast is introduced, that produces oxidative stress. So the kidney, which is very sensitive to damage, are receiving even more aggressive induction of hypoxia. And also there is a direct tubular damage because of these high osmolar compounds. In the ESUR guidelines, they say that there is no differences in multiple meta-analysis, no evidence that the isoosmolar are exactly different. No, they are not different to non-ionic or low osmolar. I remind you that low osmolar means hyperosmolar, of course, with osmolarity about 450 up to 800, comparing to the 290 osmolarity of the blood and the isoosmolar. Okay, let me to comment a little bit about this sentence. The references that they are based are 97 to 100. Okay? 97, there is not meta-analysis. 97 is a study showing that the isoosmolar is similar to no contrast. 98, they conclude that the isoosmolar is better than intra-arterial aeroxol with renal insufficiency. 99, they conclude that better isoosmolar, but the difference is not significant. And 100, they say that isoosmolar is better than intra-arterial low osmolarity. So, okay, of course, there are studies that didn't find any difference between isoosmolar and low osmolar. But many of these studies are retrospective. They do not consider neither there are different radiological procedures, different volume and contrast, different definition, and different irritation. So it's really very difficult now to find differences and improvement in one and the other ones. But in any case, I do not support necessarily the conclusion of the ESUR guidelines, particularly because they are based in 4 references that do not support the statement. But considering the ischemia of the kidney, considering the the hemodynamic change when the patient is receiving such amount of high osmolarity contrast, I would guess that it's much better to have precaution, particularly in high-risk patients, and particularly in cancer patients. Not all of them, of course, but I consider they are high-risk patients. And at the same time, this sentence of the ESUR guidelines, they are not in consistency with these European and American recommendations. For example, the guidelines for medicine optimization in NHS, they said that incidence of contrast-induced acute kidney injury is lower with isoosmolar. The KDIGOLA guidelines, they said that in some study, not in always, isoosmolar are similar to low osmolar, but wherever it's possible in patients with CKD, this is KDIGO guidelines, is just for CKD patient, they said they should be used isoosmolar in patients at the risk. The American Society of Nephrology, geriatric, people with 70-year-old GFR 60, 50, 70, depends more or less. No? So they said that renal protection strategies include, among others, IV hydration and isosmolar contrast media. And also the American Society on Nephrology curriculum, in which they said, and they consider as well, oncology patients as risk patients. So in summary, cancer patients should be considered at high risk for acute kidney injury. I would guess that some of you are convinced, at least one, after the talk. Diagnostic radiology procedure and treatment should be personalized, including IV hydration, contrast volume reduction, timing in relation to other potential nephrotoxic drugs, and choice of contrast media type. In any case, I hope that you get the most important message today is that cancer patients shouldn't be excluded as risk patients in front of the administration of contrast media for control of the disease. Thank you very much indeed for your attention.